Good morning. Thank you for making the time, and I think most of us know you. We've seen your biographies and it's up on the web, and I think by now you know who we all are, and I'm very grateful for your time, and I really appreciate that. And I think, you know, we have a we're looking forward to your contribution. I think, you know, mental health is a big issue, so delighted to have a couple of people from Mind, and we've worked with Mind before. I personally have. They're a fantastic organisation and huge impact, and also Carol from Macmillan, you know. So we want to really seek your thoughts and views about this commission. I think more importantly also, I want to specifically see, you know, NGOs have a huge role to play, the voluntary sector, and sort of intermittently we forget that. And it's always important to remind ourselves of what the voluntary sector has done, and we're very keen to see your views and thoughts of what this commission should do. And you know, what's the mayor, and how could the voluntary sector also engage with the bigger picture of what the mayor is trying to achieve. So it's all yours. If you could tell us a few words of your thoughts, and then my colleagues here would be very keen to ask you some advice. Thank you.
Thank you.
Thank you.
Shall I start? Okay.
Yeah.
Thank you for inviting us. I'll be relating specifically to my experience in Bexley, in Outer London Borough, but also taking some of the good practice across the Mind network as well. Some of the things that I wanted to talk about was the issue of long-term conditions and medically unexplained symptoms, and the role that mental health and prevention can play in terms of decreasing acute admissions and also access to GP appointments. So at Mind, in partnership with SLAM, we've developed a Pathfinder site for long-term conditions and medically unexplained symptoms, using cognitive behavioural approaches and mindfulness with great success. And this is an example, I think, of the voluntary sector and a secondary, foundation trust coming together and sharing resources and experience and looking at good practice. And the advantage of having something like this in a community setting is that you can also access some of the other services that we provide, so that the services are very holistic and person-centred. Another example that I wanted to talk about was the involvement in the integrated care pathway in Bexley, the JSNA, and how the voluntary sector and service users have had representation in order to develop care pathways. And through that, we're able to look at education and knowledge transfer in primary care. And as we know, the mental health awareness among some of our colleagues in primary care, it is poor. But because we're actually sitting around a table together, we're able to share resources, and through that, we've done some very innovative work through a 10-minute CBT program with every single GP in the Bexley area, therefore increasing awareness of mental health, being able to look at prevention and referral pathways, and also improving the link between primary care and secondary care, which is incredibly important. And just some of the other initiatives, low-cost initiatives that we have found across the network to be very successful. One is the social prescription, looking at GPs prescribing into ecotherapy initiatives, green space initiatives, developing peer support, and also looking at the carer in the pathway, so that the triangle of care involves the carer, because as we know from the recent research by the Royal College of GPs, that the mental health prevalence amongst carers is on the increase. So therefore I think it's important to work holistically and to involve other agencies, GPs, carers and the voluntary sector in a pathway. And through that we're hoping to have a JSNA which is also user-centred as well. So there's some of the initiatives that from Bexley and from the Mind network that are proving to be very successful.
Thank you.
Expand on that?
I'll just say some general comments. Excuse me.
where I've been hearing, and this is very true in Brent, where I am, that there is much more emphasis on pooling funding, on targeting resources and commissioning with the local authority and the CCG to jointly commission. And clearly where there is issues about duplication, to see how to reconfigure service delivery to make sure that there is the spend is most effective in meeting the need. What I would say is that being very much on the front line, because that's what we are very much a local mind association, is how we can make a difference in the community and have a real say in what goes on. Because clearly one of the issues for us locally is around diversity. Brent is probably the most diverse borough in London, and there are issues about how particular communities view mental health, so that can basically put back when they engage in mental health services. So it actually means that people are more advanced in terms of the problems that they have. The communities themselves can ostracize people with mental health problems, so they don't get support within their own communities. So it's actually changing some of those views, very much on the back of the sort of time to change type initiative that you've probably heard about. It's also about how you look at culturally sensitive services, so when people are engaging, it's more understood the perspective they come from, because they may focus more around physical health, but an underlying is a mental health issue, which is somewhat hidden. There would also be a view that there is a real disparity in most deprived areas of Brent and in different parts of London, where people have lower life expectancy. And often you can find that people with complex needs, so they may have substance use, mental health problems, also have physical health problems, which would obviously have a cost to the care system. So it's looking at prevention measures so that they don't engage as soon, and perhaps you can limit the impact of their care in inpatient care.
Thank you. Yeah, thank you. Carol.
Thank you. Thank you very much for the opportunity to input into the Health Commission. Macmillan Cancer Support focus is to improve and reach the lives of everybody affected by cancer, and to inspire millions of others to do the same, to work in partnership and to mobilise others. We do that by providing practical, medical, emotional and financial support. In London, the time is right. We have a fantastic opportunity now to work together. Tomorrow there is a Pan-London Cancer Conference. Macmillan is working with Andy and others and with CRUK to really raise the importance of cancer in London. And I look forward to that conference tomorrow to have a really strong dialogue with commissioners. So back to what I want to focus on today. We have a fantastic opportunity now to scale up and move at pace new ideas of transforming cancer care in London. I want to focus on three things. The importance of the fact that the cancer story is changing. We've heard this morning already the fact that we have 1 million people living with cancer now. There will be 2 million by 2030. What that means for London, 200,000 people living with cancer, 400,000 by 2030. We need to raise the importance of telling that story, showing the evidence, and really focusing on what we need to change in cancer services. There are still marked inequalities, marked problems in access, and we need to really, really focus on primary and community care. We need to move to thinking about cancer as a long-term condition, and the fantastic opportunities we have in London aligned to the integrated care work, aligned to the importance of self-management and new ways of delivering self-management in primary and community care. And I welcomed Stephen Dorrell's opportunities about new ideas and opening the world to the voluntary sector and others about exploring new ways of self-management. And finally, patient experience. Macmillan is doing a significant amount of work with Shelley and with others across London. We need to transform patient experience and scale up the current work that we're already doing. In addition to some of the issues that Shelley raised, the transition and communication with primary care has to radically change. The importance of assessment and care planning. Currently, only 24% in the patient survey reported having an assessment and care plan. We need to move forward with an integrated recovery package for every single patient in London, assessment and care planning, treatment summary with the primary care, follow-up in cancer care review in primary care, and that wider range of information and support, physical activity, psychological support, and new ways of buddying and volunteering and social networks. There's a lot here, but those three areas, telling the cancer story in London, doing that in new ways, showing everybody the importance of taking responsibility for their own health, then treating and aligning cancer with long-term conditions as part of the integrated pioneer work, but also commissioning in new ways. Macmillan is working in Staffordshire to pilot a new commissioning model. We need to do that in London too. And then in patient experience, we need to find new ways of having patients at the centre, new ways of user involvement that are radically different than what we do currently. And Macmillan is very keen to be testing these new ideas. So finally, we, for example, have been exploring a partnership with Skype for volunteering online. We have a partnership with Boots for widespread information and support for cancer on the high street. And we have a partnership with Walking for Health to move forward those examples. I look forward.
Thank you. Thank you. I hope, Carol, you've written to Andy with these ideas. Have you put a submission yet?
We are in the process of putting a detailed submission and look forward to the opportunity for that.
Fantastic. Thank you. Thank you all. So anyone wants to ask questions? Yes, Andy, and then Tracy.
To your point, David, with regard to medically unexplained symptoms, under Healthcare for London, there was a significant amount of work that was done addressing that particular issue, and it failed to gain traction. And yet we know that a lot of patients who turn up to clinics every single day do not have absolute clarity of diagnosis because there's a psychological component. So why has it not gained traction? And what do we do? What can we do? Is it because the evidence base isn't there for success?
Yes, I mean, the Department of Health funded a Pathfinder for the medically unexplained conditions last year, and the evidence is now only 12 months down the road. However, I think there's 4 pilot sites, of which ourselves and SLAM are one. The evidence so far is proving very successful in looking at some of the mental health symptoms, particularly around anxiety and depression, and looking at other preventative measures for that, and using cognitive behavioural therapy and mindfulness to better manage those conditions. But I think you're right, the actual long-term evidence isn't in there yet in the framework.
Could you make a submission just based upon that issue, actually, because that would be very interesting. And I'd like to turn to Carol as well, because we know that and I've referred to this already, is that patient experience is poor generally in London. In cancer it's particularly poor. What sort of impact would enhanced psychological therapies have for cancer patients in improving their experience? Do you have any evidence base around that?
Interesting question. We are in discussion with some work going on at the Haven with Caroline Hoffman, showing the evidence and support for mindfulness. We've also published a report in February about the importance of recognising isolation in cancer patients, and therefore very keen to explore the focus, a much more increased focus on psychological support, more widespreadly available because of the reducing social isolation. I think the role of volunteering and social networks is also hugely important. 1 in 4 patients who have cancer do not have the support of family and friends during treatment or after.
Okay.
David, you made a throwaway comment in the start of your introduction about access to GPs, and I just wondered if you'd sort of expand on that a bit and also say how that impacts the patient experience.
I mean, over the last 4 years, we have been developing our IOP service in partnership with GPs. So our counsellors and our CBT therapists are actually based in the surgeries. So being actually integrated in the primary care settings across the borough has enabled us to have access to GPs, and working very closely with the GP mental health leads has enabled us to look at the care pathway, and through that's improved knowledge across the actual GP network. I mean, it has taken time. There's also a new integrated pathway in Bexley, which is set up between primary care, secondary care, the local authority and commissioners and the voluntary sector. And through that, that's a very good mechanism for also highlighting change, for highlighting pathway and recovery. And it's through education. I mean, I think one of the problems we have is through locum GPs who come in, who are transient, and it's involving them in the system so that people are being referred to the correct form of therapy, are not bounced back between secondary care and primary care. But I think it's through education and it's through training, and also being able to have presentations and GP cluster networks, for example, is another mechanism. And you know, so they feel part of the process and better understand mental health.
So Carol's sitting there nodding her head. Is this transferable then?
I think the importance of aligning cancer care to models of integrated teams and how you deliver cancer care in primary and community care with multidisciplinary teams, with shared IT, with health social care coming together. I wrote down when people were talking earlier about organisational development and about culture and behaviours, and I think opportunities for GPs, community staff, practice nurses to come together with clinical nurse specialists and consultants and talk and have conversations about understanding each other is hugely important to bring about the change, and to spend time on actually putting in place communities of influence or opportunities to do that, I think needs to be considered alongside the practical moving forward of integrated teams.
Thank you.
Yeah, please.
Seems like a common theme is around navigation, isn't it?
Yeah.
Between different sectors in terms of mental health care, and then, you know, with patients with cancer who've got some of the most complex sets of interactions with the medical profession, both in the acute hospital setting and also out in the community. How do you think we should look at this process of navigation? Because it's often where the patient experience actually falls down, is the interface between the different steps. And what sort of organisational reconfiguration do you think would help really in terms of making that navigation easier, more flexible and more patient friendly?
I think there's different opportunities. We've been piloting a number of care coordinator roles and the importance of a navigator. I think clearly the clinical nurse specialist in cancer is a very effective care coordinator in acute care. What we're exploring is how to develop that in an appropriate way in the community. Training practice nurses to deliver and be confident in cancer care is a key way. It's when to align this with broader care coordination roles or whether to be cancer specific. And I think federated groups of primary care clinicians coming together is a key part of this. But also I think looking at patients and people affected by cancer themselves as being a navigator and being a buddy and I think we need to radically look more differently about how we're involving patients in being the navigators themselves with support.
I was just adding that along that line before, is around really looking at services, for example, as experts by experience. It's by them talking directly about what works for them, how to deliver services which can basically meet their needs in a better way. It's having that level of engagement, which there is pockets of good practice, but it's actually making that more than more.
Also about the triangle of care, so you have the service user, the family, the carer, the secondary provider, and maybe in our case the voluntary sector organisation working together, and you know, the common sense confidentiality issue as well. I mean there are lots of challenges around that, but I think it is coordinated. It's having people working together and recognising that the service user is the actual expert. And putting trust in the service user with the right care support and mechanisms behind them to develop their own personal recovery model. Not easy.
You all right, Nick? Yeah, thank you. Just a couple of questions from me. I remember the major investment, this significant amount of lobbying from Layard in 2007, and I think we invested about 450 million in CBT. we fill these positions? Do we have enough therapists out there? Did we spend those 450 days?
I think there is an issue around access to psychological therapies, and
so there's still a supply-demand issue.
There is a supply and demand issue, and I think what Daniel was highlighting about budgets being ring-fenced for the improving access to psychological therapy mechanism for support. I think there are issues around that.
Okay.
And the other issue is around the prevalence, which you may be familiar with. The 15% prevalence is perhaps needs to be looked at again. And I know the London IAPT board and the national board are looking at that in terms of maybe being slightly unrealistic in line with the current workforce.
Sure. I mean, recently we've all were involved in including Mind, in quite a big global meeting where mental health was strongly featured, and it seems that many of the emerging economies are leapfrogging us, despite not having any CBT therapist, despite all the challenges of cultural and language issues that come with cognitive behavioural therapy. And I just wonder why, and should we, in London specifically, because of the diversity of the population, because of the cultural differences that we have, the idea of putting, an English-speaking CBT therapist in front of someone who's, their English language is not the first. What should we do in that area? I'll appreciate some input from that. You've done that. You've contributed to that global report, which attracted a huge amount of attention. If we can get extracts from that, the role of technology with different languages in supporting the mental health burden in London. We have SLAM in London. SLAM is considered as globally, wonderful organisation, and I'll appreciate some feedback to us on that. The other thing I'd like some feedback on also is the, part of this commission, the unique feature of this commission, and one of the reasons I really got excited about this, is the mayor has a number of other areas of interest. I mean, this is his new thing in health, but, Transport for London shows some fantastic figures in increasing the exercise rates of Londoners and the impact on that in mental health or cancer, to that fact. So, how could we join up our commission and, what is your recommendations? What could we take for Transport for London in relation to Boris bikes or Boris walks or whatever you want to call them, exercise and mental health. The other one, which I also want you to think about, is the Metropolitan Police. We have some serious challenges with people, migrants, who we don't have their health records, and there are issues of confidentiality in relation to their health or exchange of information on the health records, which also would like your involvement in engagement and help with, because we need a very clear set of protocols on these, because they're becoming they are the ones who are going to the wrong place at the wrong time, which is the accident emergency department, which is the worst place to go to. So I'll be grateful, for that information if that's possible. Anything else? I mean, the patient experience things, I think you've told us 3 things that needs to be done. Interestingly enough, none of the 3 things were workforce related. They were process related. They weren't human capital. And I know Shelley covered that in that you've added a few things, but we really do need to know what are the 3 things to improve patient experience. Because the other thing that saddens me about the patient experience is that some of these organizations that have the worst experience also have some very good outcomes. So their outcomes of care is good, the experience is poor, which is diabolical. Imagine having a fantastic cure of cancer, but a terrible experience. We just need to get that weighting calibrated. The weighting is not calibrated at the moment. We need to make sure that happens.
And I think there is a huge commitment now in individual trusts and Pan London for patient experience. What we have to do now is scale that up, share even more, do even more research, and really focus on those most important issues. Another thing just to bring in more broadly is the alliance and the work that's going on in an organisation called the Richmond Group that Macmillan is part of. So the importance of different third sector organisations coming together to really act as one in raising the importance of engaging with the third sector, not only with delivery, but also in new ways of commissioning. So I think that's just another really good example of how we want to influence. And then finally, for example, a few months ago we held an event in Parliament. I think, Nick, you came to that, to raise the importance of patient experience. So we need to find broader ways of raising the importance and lobbying, and the Mayor's Commission is in a very strong
Great.
place to do this.
Any new ideas on improving patient experience, whether it involves politicians or clinicians, then again, please, and I'm looking for all ideas, including wacky ideas.
Fantastic.
That's what we're all about. We want
Great.
to find out everything, but obviously we look at the evidence base just in case something gets reported. So thank you very, very much for coming. Very, very grateful. And thanks for all what you do for London. This is appreciated by all stakeholders, having the voluntary sector doing so much for London's healthcare. So thank you.